All right, good afternoon, everyone, and welcome to the first session of the Tribal Public Health Data Modernization Learning Community. Today we're going to be talking about electronic case reporting and data modernization 101. It's going to really be an introduction to this work and how this work looks for tribes. So thank you all for joining us, and we're really excited to get started. Before we get started, I just want to remind you of some webinar protocols. These are just best practices to make sure our meeting doesn't get disrupted. So if you are not speaking, please keep your phones and your microphone on mute. This just avoids having background noise. As much as possible, please save your questions until the question and answer portion of the PowerPoint. If you do have questions that are about logistics, feel free to write that in the chat as we go. But we ask that you save the big questions for the presenters until we have the Q&A. And then finally, you can use either the chat box or the phone line for questions. At this time, we will be keeping both open and allowing our people to unmute at any time. We do ask that if there are any issues with sounds, use the chat box and we will mute participants in that case, but we will try to keep both open. And please note that this meeting is currently being recorded. If you don't consent to being recorded, you're asked to drop off the meeting at this time. We're going to give you about 30 seconds to drop off if you do not want to be recorded. Thank you for your understanding with this. For those who are being recorded and consent to that but are uncomfortable asking questions, we will turn the recording off at the end to allow a few minutes without recording. I'm free to ask any questions that you may not want shared. So to get started, this webinar is hosted by the National Indian Health Board. The National Indian Health Board was established by the tribes to advocate as the united voice of federally recognized American Indian and Alaska Native tribes. We seek to reinforce tribal sovereignty, strengthen tribal health systems, secure resources, and build capacity to achieve the highest level of health and well-being for our people. Specifically, this is a public health policy and programs department project. So the public health department has our own vision statement, working together to empower sovereign tribal nations to improve equity, policy, and public health systems that build thriving Native communities now and for the next 7 generations. I also want to acknowledge that this project is made possible with support from our partners at the Centers for Disease Control and Prevention. We do have speakers from CDC here today, so they'll be introducing themselves shortly, but we really thank them for their support for this work. And before we get started with the actual presentation, we're going to take a minute just to introduce the National Indian Health Board staff on the project. So I'll go first. My name is Sarah Price. I'm Programs Director with the National Indian Health Board's Public Health team. I oversee our work in infrastructure and infectious disease, and I've been with NIHB for 6.5 years now. And Sophie, feel free to introduce yourself.
Hi, I'm Sophie Sambajwe. I am in charge of the ECR surveillance and data modernization efforts in the public health policy and programs at NIHB. And I've been there a couple of months, and I'm looking forward to working closely with everyone in data modernization and ECR. Thank you.
Right, so we wanted to give you a little background about data modernization and why NIHB is involved in this work. So our goal at NIHB is to support tribal data sovereignty. Our primary role is an advocate for the needs of tribes in all work related to health and public health. So for this project, we're really focused on data access, data sovereignty, and how data modernization work can help support tribes in exercising their rights to practice public health and to protect the wellness of their own citizens. So public health in general is charged with addressing health equity and protecting the public's health. And public health data, I think everyone on this call knows, is really a necessary component to identify, respond to, and mitigate public health threats. It's really key for decision making. As sovereign nations, tribal nations have inherent public health authority. So this means they have the legal authority to receive and use public health data to protect the health of their nation. We also want to acknowledge that tribal epidemiology centers are designated public health authorities by law, and they also have this right to support tribes in this work and access public health data. Indigenous data sovereignty is the right of Native nations to govern the collection of this data. So you'll hear us use this term a lot, data sovereignty. Tribal serving public health organizations unfortunately face really unique challenges in accessing public health data. And this means that they are often not able to carry out the public health activities that we know are necessary. So they may be unable to identify disease burden. They might be able to access some of their own data. So a lot of tribes do collect their own data through community health assessments, through hospital and clinical work, but a lot of that data that is connected by other clinics outside of the tribe, by federal, state, and local partners and researchers is really not accessible. We know the Government Accountability Office in 2022 came out with a report that said that both tribal epidemiology centers and tribes were severely delayed in receiving COVID-19 data, which made it really challenging for tribes to do things like following up on cases and contact tracing. We actually heard that techs were delayed up to 7 months in receiving this data, even though it's really necessary to receive that data instantly. So data modernization presents a really great opportunity to address some of these challenges. Because without that real-time access, you can't make those decisions. Having data modernization efforts can help tribes get that data faster and be able to do this work in real time. The goal of data modernization initiatives, then this is directly from CDC, is to get better, faster, actionable insights for decision-making at all levels of public health. The systems developed through these data modernization efforts, such as electronic case reporting, which we'll discuss a bit more later today, have the opportunity to really improve data access for tribes because it is real time. It also is meant to reduce the time that data professionals spend cleaning and analyzing and tracking data so that they can spend more time on actually using that data to practice public health. So NIHB is playing a role in this. We have some key functions that we've been doing. We've primarily been involved in electronic case reporting efforts. So through that electronic case reporting work that we're doing, we've been providing direct funding and technical assistance to tribes and techs to implement ECR projects. ECR is electronic case reporting. We provided tribal-specific trainings and resources on ECR, data sharing, Indian public health law, and other relevant topics. We host listening sessions with our federal partners, including CDC. We have an electronic case reporting for tribes roadmap that's coming soon. We're expecting that this summer. And we're working with tribes directly to help them strengthen data sharing agreements with states and local partners. This particular effort is going to be under our training and resources efforts. So we are going to be hosting these learning community sessions regularly. We are planning to host 3 more sessions throughout the summer, 1 in June, 1 in July, and 1 in August. And they are going to tackle a variety of topics, including tribal public health authority and what that means, listening to success stories from tribes that have done data modernization work, looking through guidance and national guidance on how to do this work, and other relevant topics. But we are going to ask you at the end of this session to recommend any other topics that you're interested in, take that into consideration as well. And just so you know what has occurred so far in Indian country with NIHB, with support from the CDC, we've administered over 1.5 million in funding to 3 tribes and 1 tribal epidemiology center, specifically to connect to an electronic case reporting system. And again, we'll talk more about what that looks like in a minute. 2 tribes used those funds and were successful in connecting to ECR, the Turtle Mountain Band of Chippewa Indians and the Salt River Pima Maricopa Indian Community. They are the first 2 tribes in the nation to connect to this platform. Many states and locals have done so, but these 2 tribes have really led the way in this data sovereignty effort and in getting this data. We also have 2 current grantees that are looking to pursue ECR connections by the end of the summer. That's the Tule River Health Center and the Great Plains Tribal Epidemiology Center. And other DMI news in Indian country, IHS has selected a electronic health record system to replace our PMS. So when we're talking about data modernization in this learning community, we're talking about public health data systems, but those data systems do require healthcare systems to be interoperable. So this is a huge step for making sure that the data that IHS is collecting will be available for public health and will be readable for public health systems as well, which is why we think this is really important to follow. There are a lot of opportunities to get involved beyond this learning community. As we develop guidance for electronic case reporting and other data modernization efforts, we're really looking for your expertise. So please feel free to reach out to us if you're interested in participating in focus groups or just talking to us about your needs. We'll talk about implementation strategies, surveillance, data sharing challenges, and legal and policy factors. So please feel free to reach out if you want to get more involved. We also invite you to sign up for our Tribal Data Modernization Learning Community listserv. Sophie is going to share these links in the chat so that you can click on them, and we'll share them again at the end of the session as well as by email. But if you sign up for this listserv, it will be information that we will share out, including resources, opportunities, as well as the dates of the next learning communities. We also hope to share a new funding opportunity for electronic case reporting and data modernization in the fall of 2024, but that will be pending funding availability. If you are working in data modernization, we also suggest that you consider the PHII Data Modernization Learning Community for additional support. This learning community with support from the apologies for that. This learning community with support from CDC has additional resources, although it's not tribal specific, state and local practitioners will also be in this learning community. There's some really great resources if you're learning more about data modernization and want to ask questions of other people doing this work. And then finally, we want you to complete today's evaluation, letting us know how this session went, what you want to see for future sessions, and what you've learned. And we also want to remind you that the National Tribal Health Conference is coming up May 20th through 23rd in Rapid City, South Dakota. We will be hosting a data modernization listening session in partnership with CDC on Monday, May 20th. That will be 3:30 to 5:30 p.m. It will be in person only. And this session is no cost, so you do not need to be registered for the whole conference to attend this session. That being said, the conference is a great opportunity to learn more about data modernization. We are going to have several presentations on data modernization, data exchange, different surveillance topics, and other relevant pieces. So definitely urge you to look into this if you haven't so far. All right. And with that, I'd like to introduce our CDC partner, Dr. Sarah Sabonia. Sarah, if you want to introduce yourself, we'll turn this over to you to talk about electronic case reporting 101.
Yeah, thanks, Sarah. Yeah, I'm Sarah Sabanya. I coordinate our health equity activities on the CDC electronic case reporting team. I also coordinate our onboarding activities, our onboarding of healthcare organization facilities, and also electronic health record vendor facilities. And I'm also joined by my colleague, Melinda Thomas, who leads our public health agency support team, which includes supporting tribal public health agencies, either onboarding to ECR or already receiving ECR data, and helping them kind of do what they want to do with the data. So let me try to share my screen. I think I should have practiced this. All right. I think I may not put this in presentation mode if everyone can see the way it is. So I'm going to talk about what electronic case reporting is, and just kind of go through the process. It's complex, and so if you don't understand kind of all of the terminology, that's fine. We don't, really expect that from everyone, but just want you to kind of understand the data flow. And then, of course, if you have questions, you can always reach out to us for more of that technical explanation. Electronic case reporting is the automated generation and transmission of case reports from the electronic health record to public health agencies for review and action. So let me skip down to this one. Actually, this is our flow chart. So this is kind of the infrastructure of electronic case reporting, and I'm going to come back to this one over and over again throughout the presentation just to kind of ground us in what this process is. So the first thing to know is that this is a process where the data is coming from your healthcare provider and it's ending up with your public health agency. So I know with tribes, often these are very interconnected, right? Your public health agency and your tribal health clinics, may be in the same building, they may be sharing some systems. And that happens with some, especially local public health agencies. One of the benefits for electronic case reporting is that your tribal public health department can receive data about one of your tribal members if they receive care somewhere else. So perhaps they go to a larger hospital or they're visiting another city, but they live on the reservation. That data can then be shared back with your public health department based on patient residence. And then you'll know which reportable condition your patient and your tribal member has. So the way the data flow works is you start with the healthcare provider on the far left. The provider enters something into the electronic health record software. Just could be a diagnosis, it could be a lab test order, it could be a lab test result, something like that. And we'll talk about what trigger codes could be. That triggers an electronic initial case report, which is sent through to this intermediary AIMS platform. There it's compared to the rules for reportability from all the different public health agencies. And then it's sent on to public health agencies to which that case is reportable that have jurisdiction. So it can be sent on to your tribe if the tribal public health agency, is where the care was provided, and say the person is living somewhere else, or maybe isn't even a tribal member, the report can be sent to a different place as well. So the benefit for healthcare providers, right, are already doing this required reporting. They're reporting to public health departments for reportable conditions. I think we're all familiar with COVID as a reportable condition, but there are lots of others. There are over 200 that are available right now. And so instead of having to send a phone call or a fax to the public health department, electronic case reporting can take care of that. Streamlines jurisdictional reporting challenges. So if there are multiple jurisdictions involved, if the state and the tribe both should receive that report, they can both receive it at the same time, and the tribe doesn't have to wait for the state to then share the data back to them. Electronic case reporting also allows a public health department to share information back with the healthcare provider. So when the public health department is entering their criteria for the reportable conditions, they can include, say, a website, for more information about current outbreaks of a condition, check out this website where they'll share more information, or testing sites or treatment recommendations, whatever they want. For healthcare providers, it fulfills legal reporting requirements, can be implemented for all reportable conditions now. We have over 200 reportable conditions available. And if the provider is participating in the CMS Promoting Interoperability program, this will fulfill the requirement for ECR. Benefits for the public health agency. So one of the things that Sarah Price touched on was the difficulty that many tribal public health agencies and also tribal epidemiology centers had, during the COVID pandemic, was not receiving data in a timely way. So with this way, the public health agency is receiving the data in real time or near real time. The report is triggered, it's sent electronically to that intermediary platform, it's compared with the rules from the jurisdiction, and it's sent right on to the public health department. So depending on the capabilities of the electronic health record software, the public health agency could be getting the report in minutes, and they would definitely get it within an hour. It allows the public health agency to communicate back to healthcare. They can communicate back directly through that response. That's that bidirectional exchange. And also the data that's provided is more complete data. Sometimes public health departments would get a lab report that would include, maybe the name, but it wouldn't have the birth date. It wouldn't have race or ethnicity data, wouldn't have an address. So if the healthcare department wanted to reach out to the patient, to check up on them for more guidance, they wouldn't have a way to do that. All right, so back to our data flow diagram. I think we're going to talk a little bit about what the triggers are, what kinds of things could trigger that initial electronic case report to be generated and kind of start this path. So kinds of triggers could be a problem on the problem list, a diagnosis, could be lab testing, lab results, medications and immunizations, kind of in progress, but those are still to come. So we talked about this electronic initial case report. So what is an electronic initial case report? They include the CSTE identified data elements necessary for public health to initiate a case investigation. You can see for yourself the implementation guide. This is available online. It's either an HL7 CDA document or FHIR. And let me just skip down to what data is contained within that electronic initial case report. So again, it's aligned with US CDI. Release 1.1 is the release currently in use. So the report would include this data here. Also this clinical data. We found that patient occupation has actually been really interesting and useful to public health. California published an article recently about how they identified an outbreak of a condition based on a patient occupational data. And then the new version of the EICR implementation guide is going to include these additional elements. I believe this needs to be implemented in 2025. So it's not available now, but starting in 2025, your public health department will be able to get things like tribal affiliation, tribal enrollment status, as well as these other additional elements like disability status and homelessness status. Again, if those are shared with the clinician. Let's see, going back to our infrastructure. Sorry, okay, so we talked about the data in the initial electronic case report. It's coming from the provider, from those trigger codes, and then the may or may not go through an HIE, and then it's going to land at this intermediary AIMS platform. This is run by APHL, the Association for Public Health Laboratories. AIMS is APHL something messaging service. And ECR is a joint project with CSTE, APHL, and the Council of State and Territorial Epidemiologists. So RCKMS, this knowledge management system, is in the middle, and this is like the brain of ECR that decides, you know, who should this report be routed to, if anyone, is it reportable? So it's RCKMS, the knowledge management system, consists of three parts. There's the authoring interface. The public health agencies have a login. They would log into this intermediary RCKMS platform. They would enter their local reporting requirements based on their laws or municipal codes or a tribal council resolution. Anything that requires healthcare providers to report to public health cases of some kind of illness. So public health agencies log in and enter those requirements. We've got CSDE has a great RCKMS team. They've got authoring support associates who will help your public health department understand this system. They will walk them through the process of authoring, entering their criteria. They're really great with that. So that would happen first. That knowledge then is stored in that RCKMS platform or RCKMS repository on the AIMS platform. And then when a case comes through, the decision support service determines, is this reportable based on the criteria that are entered by this jurisdiction, or is it not reportable? So for example, a jurisdiction public health agency might only want COVID cases where the patient is hospitalized. So as they're doing their authoring, they would enter the requirement that patient location is in the hospital. So then if a report came through that was triggered on those COVID triggers, like a diagnosis of COVID, it would get to this intermediary platform and say, oh, this is in the right place. This, you know, this person lives in this jurisdiction, but they're not hospitalized. And in this jurisdiction, COVID is only reportable to the public health agency if the patient is hospitalized. So that's what's happening on this platform. And then you'll see they talk about a reportability response. We've got the electronic initial case report going forward, and then this reportability response going back to the provider. So what is that reportability response? It includes a report of the condition, what jurisdictions received the report, that optional additional information we talked about, such as treatment guidelines or local context, and also some processing or, if there's errors or something, it would include that information. So the reportability response, we've got the report being triggered, comes from the provider, goes to this decision supports engine. If the case is found reportable, then the report, the EICR, and also the reportability response both go to the public health agencies. If the case isn't reportable to any public health department, that only the reportability response goes back to the provider, and it will say a report was triggered, but it wasn't found reportable to any jurisdictional public health agencies. So the provider always knows, did we report a case? And if so, who did we report the case to? And what was it reportable for? All right, and I think that's the full picture. I mean, the other thing is that we are happy to help any tribe that wants to connect. As Sarah Price said, a tribe is a public health authority. There's nothing special that you would have to do. It's just an innate thing. So if your tribal public health authority, your tribal public health department is interested in receiving ECR data from providers, feel free to reach out to ecr@cdc.gov, or you can reach out to the NIHB team. They can also kind of send you our way. We offer technical support for getting connected. We offer technical support for using the data. We offer technical support for that authoring, which I talked about. So, we're here for you, and let us know how we can help. And this is our appendix. So we have a website here, the cdc.gov/ECR. If you'd like to go kind of see more, there's a video about how this works, and there's more information there as well. All right, so then I'm going to pass it over to Rachel and Jim.
So I think before we pass it, we just had 2 or 3 questions in the chat that we could just address while we're all thinking about ECR. And we could just see if anyone has any other quick questions, and then we'll do a bigger question at the end. So one of the questions, and Sophie did message this back in the chat, but does it matter what electronic health record system you have, or is this just for the new system that IHS is getting?
It does matter. Right now, we are working with over 70 different electronic health record products. We have 11 in what we call general availability, meaning they're onboarding their customers, just anyone who reaches out. We have another, I think, 10 or so that are what we call working with initial implementers. So they're working with just a small handful of clients to, work with real patient data, fix any bugs that they have. There's a list of those on our public facing website that we update anytime we move a new one into general availability. Unfortunately, our PMS is not ECR capable at this moment. We've had a few meetings with the IHS RPMS development team, and are happy to continue working with them. But since, as you said, they are moving over to a new system, they, I think, are probably not going to put a lot of resources into that. But the good news is that the new system that they're moving over to is based on an Oracle Cerner system, and Oracle Cerner's Millennium, actually, I think 3 of the Oracle Cerner products are ECR capable. So, we've had, again, regular discussions with the IHS. We anticipate that if additional development needs are required in order to make sure their new product is ECR capable, that they'll be on board with that. But there shouldn't be a lot required because, again, the base product that they're using is ECR capable.
Okay. And then the next question, for tribal affiliation and tribal enrollment status, would those data points need to be collected in the electronic health record?
Yes. When that data element is rolled out, which again, that's the future state one, they would have to be something that was captured in the electronic health record software. So, and I think maybe that's a question for this group or for NIHB, but are there ways that could be used in the future to help route things back to your tribe if you're receiving data or if you're receiving care, somewhere besides your tribal health clinic? Or do you not want the state to know that you're a tribal member, so you're not going to populate that field or ask for that field to be populated? Or are there third options? So something to think about in the future. Thanks, Shahida. I see her comment too. Boy, all sorts of great comments. Thank you all in the chat.
And I've got 2 more questions for you. What is the website those electronic health records are listed on?
I think Melinda shared that. It's that Getting Started page.
Yeah, perfect. And then can EAMS send messages to more than one jurisdiction and based on different data element triggers, such as geographic residence, race and ethnicity, etc.?
I'm not sure. So maybe I'm not understanding the question, because the trigger codes, they can't send to more than one jurisdiction. It can go like to the jurisdiction where the patient lives. It can go to the patient's, where the healthcare was provided. It can go to, like both a tribe and the state at the same time. So theoretically, it could be multiple jurisdictions at the same time. The triggers would be the same. I think you're asking if the rules could be different. So like a case could be reportable to the Turtle Mountain Band of Chippewa in North Dakota based on their criteria, but it could not be reportable to the state of North Dakota based on their criteria, even though it's the same case that was triggered. Is that the question?
Yeah, I think that answers the question. And just for, I think, clarity for everyone on this call from a legal perspective, tribes are completely separate from the state. So you can author for completely different conditions, completely different triggers. You don't have to do what the state does. You can author for more, you can author for less. The limitations, of course, are what's available in the RCKMS system. But that's something that you can work on with CSDE if there are things that are not available that you would like to be available that's specifically important to your tribe. Okay, that is all the questions that I see for now. There will, of course, be more time for questions at the end. But I am going to turn this over to Jim Kuchik and Rachel Klopsover-Smith.
Thanks, Sarah. Really appreciate it. And I'm going to zoom out. That was a great overview of one way in which we're trying to solve some of the problems that Sarah so eloquently talked about in her opening. I think that all of you here are sort of data people, but I mean, it was really fascinating last year at the National Tribal Health Conference. I was talking with someone who wasn't a public health person, was not all a data person, but she was talking about how important data have become to her tribal community. And she said, before COVID, like no one paid attention to data. It's like, but since then, like we see ourselves in the data. My family sees themselves in the data. My community sees themselves in these data. So really underscoring like how important data are for doing everything that we do and for protecting our communities. And the CDC's director, Dr. Cohen, has said data are the oxygen that powers our ability to detect and respond to health threats. So really just a critical piece of information so that we can protect the communities that we live in. Next slide, please, Rachel. So I'm going to talk a little bit at a high level around what we're talking about when we're thinking about data modernization, how we're approaching it. And then I'm going to turn it over to my colleague, Rachel Klopsover-Smith, who's going to talk specifically about how we're actually supporting Indian country to do data modernization related activities. So Sarah gave you sort of the CDC the definition of data modernization, but really at its essence, it's about making sure that the right people, processes, and policies are in place to use public health data for decision making. That's really sort of where we want to focus on. And we understand it, and all of you are very much aware of sort of a lot of the challenges that came up during COVID. And so this whole data modernization initiative is taking the approach of figuring out sort of what some of those key stressors, stress points were. How do we correct that? How do we use modern technology to address some of those particular issues of exchanging and using data? So next slide, please. So what do we mean? What is it? What's our approach when we're talking about data modernization? One of the key things we want to focus on is breaking down some of those data silos. So we're all aware sometimes we have community assessment data, we have immunization data sets, we have some data that might be in your IHS facility, and none of these data systems talk to one another. So we're trying to figure out, how do we get those systems to talk to one another? How do we break down sort of these data silos? And some ways that we can do that is by adopting and using national standards. So standards that work across both healthcare and in public health. So these systems really can be interoperable. We also want to make sure that we are employing modern technologies to make sure that we have the infrastructure to be able to use the data. So we don't want to just sort of turn on a data faucet, receive all the data possible without the ability to actually use, analyze, visualize, and share those data. So we want to make sure that we're taking advantage of those modern technologies to be able to do that. And first and foremost, on the previous slide, I mentioned that data modernization really is at its heart: people, policies, processes, and technology. And it's in that order. We have to make sure that we have the right people. And that means developing, upskilling, retaining a workforce that can understand the informatics, data flows, and can be those who are able to use the data in real meaningful ways. Next slide, please. So data modernization, right? It's ambitious, right? That's a huge concept and approach. We understand that we can't do everything all at once. So we really want to make sure that we are keeping our focus on what we can accomplish and lay out some specific goals that will get us there. Next slide, please. So last year at this time, CDC put out the first ever public health data strategy. And this really was to be a way in which we are setting forth a path towards achieving our data modernization goals and using data to achieve health equity and protecting our communities. So the public health data strategy is centered around 4 primary goals. The first is ensuring that our core data sources, so like vital records, like ECR data, like immunization data, that they are more complete, timely, and that we can exchange them rapidly to support our data public health functions as a tribal public health agency, for example. Our second goal is making tools available so that our tribal, our state, our local, our territorial public health departments have those tools necessary to use public health data to address health disparities. The third goal really is to allow public health to be a trusted source for that real near-time visualization and sharing of data for situational awareness for the public and for decision makers. And that fourth goal is really focusing on enabling the exchange of interoperable data so that healthcare, public health departments, federal agencies can all access and use the data that they need and when they need it. Next slide, please. We recognize that there are and have been a number of challenges. I've mentioned some of these, particularly the disconnect between public health and health IT. Sarah Savania was mentioning sort of that, oftentimes within tribal public health that there's a very close relationship. But also, we understand that sometimes there's even a disconnect when you're so closely related. In one of the tribes I was working with, public health was in the same building with its 638 facility, and the epidemiologist couldn't actually get the data out of the EHR and use it for decision making, to analyze the data. So there was still a disconnect there, and we have to be able to sort of solve those. We talked about some of those siloed systems, want to make sure we're bridging those. And also we understand that so often our public health staff are spending too much time with manual processes or using outdated technology. And we want to make sure that we're able to use resources to address some of those issues so that epidemiologists can be focusing more on using data and not cleaning data. Next slide, please. So what are some of the opportunities that we really see? There's been a lot of recent advances in health IT around the areas of connectivity, interoperability, standardizations, and we want to make sure that public health is at the table and taking advantage and leveraging some of those opportunities to increase access across all levels of public health to get this data. We recognize that CDC, IHS, CMS, and other federal agencies are all sort of going through various stages of data modernization. We want to leverage those efforts to make sure that public health agencies are getting the data that they need and doing so in ways that we don't have to wait for another pandemic. We want to make sure that the systems we're putting in place can handle the volume, the types of data that might be coming in from different directions, whether during peacetime or during a pandemic, as we saw with COVID. And we want to make sure that our state, tribal, local, and territorial partners are alongside, making sure that, I mean, we recognize that we are all part of a chain and an ecosystem. We want to make sure that we are supporting through direct funding, through technical assistance, and through other additional resources, making sure that public health agencies are getting those tools that we need. Next slide, please. So what does this mean when we are leveraging some of these new technologies and standards to connect, particularly to health IT? And we know that some data comes from other places, right? Community health assessments, we get data now from schools or from a variety of places within your community, but we do recognize that most of the data that public health wants to use comes from healthcare. And we want to make sure that we're really bridging and taking advantage of these opportunities. Sarah Sabanya was pointing out the ECR is one example of how we can reduce those point-to-point connections. You don't have to connect to all the various hospitals, clinics where some of your tribal members may be seeking care, but you can use intermediaries to be able to get the data that's needed. And you can do so in near real time. You don't have to wait for these data. These technologies are helping us move data much faster. Also, we're looking at being able to have a higher quality of data, making sure that we are having the types of data that we need. We recognized during COVID that this wasn't the case. Tribes, CDC, we weren't always necessarily getting the data, all the types of fields completed that we need to be able to use our data in the right ways. And as I mentioned before, we really want to make sure that the systems that we're developing really are protecting privacy, that they're secure and sustainable over the long term. No sense in building these systems if they're not going to work for us over a long period of time. So next slide, please. So overall, we're taking the approach of a one public health ecosystem. We recognize that we are all part of this ecosystem, and we're figuring out ways, envisioning new ways in which we can make the connections so that, as Sarah Sabanya was pointing out earlier, tribes can get data that they need independently of having to go through various other mechanisms. So we want to make sure that these connection points are made. We want to facilitate those connection points and leverage some of these existing health IT issues, advances, and make sure we're getting those data and moving those data to the right places. So with that, I will stop and hand it over to Rachel to talk about how we're doing this in Indian country.
Great. Thanks, Jim. So kind of overall, CDC's approach to supporting our STILT partners, we do this through several different types of activities. First and foremost, we have the continued funding and technical assistance and the ability for our STILT partners to access those items. We do provide opportunities for and collaborations to design, test, and learn. One of the things that I did want to specifically highlight for folks in attendance today is the opportunity for participating in CDC's engagement panel. This is something that has been set up by our Office of Public Health Data Surveillance and Technology to incorporate the perspectives of public health partners into our design work for systems that we're designing and building and updating and improving. There's a bit of a explanation that I have here, but it's really, we're recruiting public health partners from across all different types of health departments and partners and folks who are maybe interested in learning more. If this is something that you are interested in, I'm dropping some information into the chat right now. There is an email address, dmibuildingblocks@cdc.gov, and you can register for that opportunity using the link that you receive. Basically, what this is by signing up for the engagement panel, you're basically putting your name on a list of people, a catalog of public health professionals who might be consulted to provide input at a future point on technology products, data policies, or modernization strategies and work that the CDC is undertaking. So we definitely encourage you to sign up for that if it is something that is of interest to you. We also have some, we are setting up some something called the implementation centers. This is an effort through our public health infrastructure grant, and I have a couple slides on that I'm going to speak about more in depth there. We also have some ongoing workforce initiatives that we'll speak more about, as well as some tools, resources, and guidance documents that we make available to all of our partners. So I said something about the implementation centers. What this is, through the overall public health infrastructure grant program run out of CDC's Public Health Infrastructure Center. This is an effort funding 3 of our national partners. The funded partners you can see there are on the left. They are the Association for State and Territorial Health Officials, National Network for Public Health Institutes, and the Public Health Accreditation Board. They have been given specific dollars to set up implementation centers that are really going to help drive public health data modernization. There are going to be 3 implementation centers set up for supporting state, local, and territory jurisdictions, and 1 that is specifically going to be supporting tribes in public health data modernization efforts. And this is additional funding that's layered on top of other funding that is already out for capacity grants and data modernization that CDC has already put out. So what are the goals of these implementation centers? This is really, these centers are really designed to establish and coordinate efforts across both across the funded centers themselves to really accelerate public health data exchange and data linkage. And the goal is really to get the data to move faster, increasing the timeliness of data exchange between healthcare and public health for those public health reporting and those priority use cases, improving response time to detecting public health threats, reducing the burden on healthcare systems and providers and public health jurisdictions themselves for public health reporting and data exchange processes, and improving data quality and completeness through various means. The other piece that I have mentioned very briefly, there is going to be a workforce acceleration initiative. This is funding that has been put out through, and we're working with our partners, the CDC Foundation, the Association for Public Health Laboratories, CSTE, ASTO, and other members of the Joint Public Health Informatics Task Force to really do some strategic workforce placement and expansion. The idea here is to identify and recruit skilled technology and data experts with certain technical competencies and skills and abilities, and to place them in public health departments who can help accelerate some of this data modernization work on the ground. The idea is to recruit, place, and support over 100 technical experts in public health departments across the country. And tribes will be a part of that process, and there will be more information about how tribes can participate in that or put their names for consideration in the coming weeks. And I want to speak a little bit about some of the direct funding investments that CDC has already made in tribes and tribal serving organizations on data modernization. We have been directly supporting tribes and tribal serving organizations through the umbrella cooperative agreements that are managed by CDC's Public Health Infrastructure Center. The amount of DMI investments through these mechanisms and the number of funded recipients have really grown from 3 recipients in 2020 to 26 specific projects with 16 recipients in 2023 and totaling more than $7.5 million. And we do understand that we have more to do to raise awareness of these opportunities to fund these data initiatives. For one of the funding streams that we had available earlier in 2023, we had the ability to fund a larger number of applications than what we ultimately received. So we recognize that there is a mismatch in funding and connecting available funding to eligible recipients. Although the purpose of these funds is to increase access and use of public health data, our awarded recipients have also had flexibility to select their funding focus areas, and many have done things like conducting a strengths-based capabilities review and accessing and using public health data for action, focusing on building data infrastructure, and highlighting priority data assets and addressing governance issues to gain and maintain access to those data assets. I do want to highlight share some examples of successes and innovation that have happened with some of these funds. Wabanaki Public Health and Wellness was one of the recipients under the umbrella. They were able to do some implementation of cloud infrastructure, as well as to identify their data assets and increase and enhance their data sharing partnerships. Northwest Portland Indian Health Board also did some work around needs assessment and planning, and they are working on developing and implementing some enhanced protocols around and data sharing agreements around facilitating data exchange within their tribal health clinics that are within their service area, and also integrating some high value data sources into their overall platform that they're developing, the Tribal Data Hub, where they are building kind of an online platform for individual tribes to access and look at their own tribe's data for certain disease areas and topics. And then lastly, with support from the CDC, the Alaska Native Tribal Health Consortium has developed out their data infrastructure to create some population health management tools that blend clinical and public health data for immunizations. They've reduced the manual burden hours for some of their data processes and created some repeatable automated processes to really cut down on the staff time that's needed to process raw data and making it ready for direct analysis. And they're improving the representation of tribal populations in their vaccination data by triangulating data sources to kind of report and accurately and report on demographic groups. That was all very fast, but I realize we are coming to the end of our time together, and I did want to make sure that we had at least a couple of minutes for Q&A and discussion at the end. So I will stop there. Thank you.
Thank you. For the discussion section, you have the option to either type your questions into chat or to unmute yourself. So feel free, if you have a question, to unmute yourself now.
Hello. Hello.
Hello. Area.
Hi. Hi. This is Laura Hayward from Northeastern California, Pitt River Nation, Pitt River Health Service Incorporated board chairperson, chairwoman. I just wanted to make a comment and just wow, that's a whole lot of data sharing that's going to be going on. I see, I see the pros and the cons with it. Really, we're very rural. We're up here in the northeastern part of California, and it looks like it's gonna rain today, but I'm not sure. But anyways, and hearing all the other wonderful things that are going to come with this data sharing, I'm just really kind of baffled by the whole thing that this is all just coming together at. I heard it, some time ago, back in the 2020 when COVID hit, but was across the nation. And today we're looking at data sharing, and this sounds like it's health. You said tribal public health authority. Is that right? And that tribes are, taking their health into another way, and I'm all for it. What maybe it's just the way I was raised. I don't know, but we're to share so much information across the country. I'm just going, wow, where did technology come from? And we got here real quick. It seems like, we're right in the middle of. We just broke ground for expansion and remodel of our clinic in Pitt River Country, and all these things that come with it. And I want to see healthcare move in a direction where we still have hands-on, and it just seems like everything just goes across the channel of the sky or the cloud. And I'm kind of just fearful about things like that, going on so fast, technology where it's at. It just baffles me in some ways that I don't for our people, we're pretty far up there in the highlands, and the broadband, it seemed like it just missed us. And we're a small tribe too. We're not real big. We're rural, and hearing the Chippewa Nation. I'm not sure how big a nation that is, but I'm excited for them. I'm excited for a lot of people, but I really want us to continue to have that continuity of care where we get to go out and sit and talk and be able to continue to do these things in the way that that we're supposed to do it. So I'm just confused about all this data sharing. This sounds like a whole mouthful of this is my full DNA, genetics, and so this. I mean, that's a lot to go across state, federal, county, health providers in general. I don't know. I like the idea. I mean, we're embracing it, but still, it just doesn't seem like this is where we're supposed to be for some reason. Just to me, I'm looking at all the trees, around right now, and I'm thinking to myself, wow, interesting. National Indian Health Board, I appreciate all the hard work that you guys do, and all the tribe across the nation. I just, it just doesn't seem. I guess it's going to take a moment for me to say this is real. This is really what's going to go on. All this data sharing. You're talking who owns all the data. Who walks. I mean, if we were to have to get up and move across the country, who would have all the data? CDC for a pandemic, or for is that the future of this world now? We have to get back to healing and
Thank you, Laurie, and I hope that you'll continue to be in conversations. I think it's really important to keep that in mind. So our goal at National Indian Health Board is this data has not made it to tribes, and our goal is that tribes own their own data to do what they want with it, to collect more data, to collect less data. That's our goal here, and that's what we're going to constantly be advocating for as we work with CDC and federal partners. Is this data, if it's being collected already, it belongs to the tribe to do what the tribe wants to do with it, not what any other organization wants to do with it. This shouldn't be the state's data. This shouldn't be the locals' data. This is tribal data. So that's where we're coming from in our role. It's yeah.
Can I ask, do we get some of the data from the Census Bureau that took place? Is that
I'm
as
not,
far
yeah.
as far as population and people, you know?
Yeah, I'm not sure what was shared back. I know that there's some serious problems with the census data, and that
Okay.
it's very hard to know how much tribal data was in there because there's a lot of the data is just identified incorrectly a lot of the time. This would be public health data, so this is
Okay.
you know, like COVID cases. If someone's diagnosed with COVID, our goal
Oh.
is that that's the tribe's decision what to do in that case. Should that data be acted on? Should that data be sent to the tribe, rather than having the states control what happens to tribal data or the locals control what happens to tribal data? So that's where we're coming from. I think yours is a really important perspective. This
I
should
just,
be a decision every tribe makes independently how they want to use data. If data, what data is helpful for them, what's not helpful for them, and how to use it in a way that helps facilitate those conversations and that actual one-on-one care in the community.
yeah. Okay. I was just thinking, and COVID is still, yeah. So, I mean, interesting. Okay. Well, thank you for your comments and thank you guys for your hard work. Appreciate it.
Absolutely. And if any other questions or thoughts come, please feel free to
And all
share
the
them.
collaboration that comes along with it.
I do see a question in the chat. I'm going to read it out. What permissions are needed and what best practices are there for an electronic health record to begin collecting tribal affiliation?
I think that's a great question. And I think it's really two questions, right? I mean, the best practices, I'm not sure that's been touched on yet. I think, you know, from the EHR development side, they'll just create, here's the place. Here's a place that is mapped to a certain field, and that way it can be pulled into the electronic initial case report, and that way it can be sent on to the public health department. So, you know, there's the technical piece, which will probably be pretty straightforward. But the best practices, I think we really do need tribal input there. And I think I know NIHB had talked probably about a year ago about, you know, will they share guidance on, you know, should you share this or should you not share this, right? Right. And as Suzanne said, like if right, we could theoretically use this data for routing if it was populated. So we could say, you know, if you are an enrolled member of the Navajo Nation, your EICR should go to Navajo Nation's public health department. Is there a way to do that so that maybe you don't want the state of Arizona knowing that you're an enrolled member of the Navajo Nation? I don't know. And that's, I think, the technical piece we'd have to think about once we figure out kind of what are the best practices. So it's a lot to think about. I'm glad we're having discussions though.
Yeah, I want to add, I think Great Plains Tech is exploring some of these with their project. This is a big challenge to figure out how to get that data for tribes living off tribal land. So I'm hoping within the next couple of months, we'll have some lessons learned from the work they're doing. They're working really closely with APHL to figure out the legal issues of which data they can receive and then sort, because they know who the members are of the tribes they represent. They can sort that, but the question is, what will be possible through the system? Will they be able to get all that data? So that's something they're working on right now, and it may be a good model where that data doesn't need to be collected necessarily in the EHR, but rather the tribal epidemiology centers will sort the data themselves at the end of it, and you know, remove any data that's not related to tribal members. But we're not sure yet how that's going to look. So I'm hoping that that will be a conversation we keep having because this is so new, and there are so few tribes and techs doing this so far. We're really very much in the pilot stage of what can this look like for tribes and techs. Yeah, I'm not seeing any more questions in the chat. Does anyone have any other questions? Feel free to unmute yourself if you do, or to write it in the chat. I'm not hearing any more. Of course, I'm going to share some contact information for us. This was a lot of new information. This is, I know, a lot to digest quickly. So I want to assure everyone that we're all available to continue to discuss this. We'll continue these discussions at the conference and at future learning communities. And we're also happy to talk to you if you have questions offline. Oh, sorry, I do see a question about the recording. The recording will be available probably by early next week, and we will send it by email to everybody that was registered for this, as well as posted online. So we will have the recording and the slides for everybody. Okay, perfect. You can see my screen, I believe. So just a reminder that if you want to be receiving more information about our tribal data modernization learning community, please feel free to sign up at this link. We will be sending the meetings out to everybody that's signed up for an NIHB listserv, but we may send resources to those specifically interested in data modernization. So I really do encourage you to sign up. And then please complete today's evaluation. We will send this by email as well, along with the recording. But it's really important for us. This is our first session. It's just to get to know each other and get to know a little about the topic. But we want to know what would be helpful for you as you consider these new challenges and consider how you want to do data modernization work, and if data modernization is right for you. So please take some time. It should only take 5 minutes or so to complete that evaluation. This is the contact information for myself and Sophie. You can contact us by phone or email. Please reach out with any questions, or if you just want to talk more. As I said, we'll continue to share information as it becomes available about opportunities to get involved. We are hoping for a new funding opportunity next year, but it will be pending funding availability, and that will be probably in the fall of next year. If you do need financial support to get started to do some of this data modernization work. And thank you all for taking the time. I know it's the end of the day and we went a little over, but we appreciate all of your attention and all of your engagement. And we really hope that this will be a helpful resource to have this learning community and this network to talk through these issues with. So thank you. I am going to stop, or Sophie, if you could stop the recording. We will stay on the line for about 5 more minutes, just if anyone has any questions that they would prefer to ask offline.